Immunoglobulins, antigen and antibody reactions, selected tests. So, the lock and keys concept. The binding site of an antibody is located in the Fab portion of the molecule and is constructed from a hypervariable regions of the heavy and light chains. X-ray crystallography studies of an antigen-antibody interaction shows that antigenic determinacy is shown at left formed by the combining site of the antibody. The bonds that hold the antigen to the antibody combining site are all non-covalent in nature. These include hydrogen bonds, electrostatic bonds, van der Waals bonds, and hydrophobic bonds. Multiple bonding between antigen and antibody ensures the antigen will be bound tightly to the antibody. Reversibility. Since antigen-antibody reactions occur via non-covalent bonds, they are by nature reversible. Antibody affinity is the strength of reaction between a single antigenic determinant and a single combining site and antibody. It is the sum of the attractive and repulsive forces operating between the antigenic determinant and the combining site of the antibody. Affinity is the equilibrium constant that describes the antigen-antibody reaction. Most antibodies have a high affinity for their antigens. Avidity is a measure of the overall strength of binding of antigen with many antigenic determinants and multivalent antibodies. Avidity is influenced by both the valence of the antibody and valence of the antigen. Specificity. Specificity refers to the ability of an individual antibody combining site to react with only one antigenic determinant, or the ability of a population of antibody molecules to react with only one antigen. In general, there is a high degree of specificity in antigen-antibody reactions. Antibodies can distinguish differences in the primary structure of antigen, isomeric forms of antigen, secondary and tertiary structure of antigen. Cross-reactivity refers to the ability of an individual antibody combining site to react with more than one antigenic determinant, or the ability of a population of antibody molecules to react with more than one antigen. Test for antigen-antibody reactions. So there are factors that affect the measurement of antigen-antibody reactions. The only way that one knows an antibody-antibody reaction has occurred is to have some means of direct or indirect detecting the complexes formed between the antigen and antibody. The ease of which one can detect antigen-antibody reaction will depend on a number of factors. Affinity. The higher the affinity of the antibody for the antigen, the more stable will be the interaction. Thus, the ease of which one can detect the interaction is enhanced. With regards to avidity, reactions between multivalent antigens and multivalent antibodies are more stable and thus easily detect. Antigen and antibody ratio. The ratio between the antigen and antibody influences the detection of antigen and antibody complexes because the size of the complexes formed is related to the concentration of the antigen and antibody. Physical form of the antigen. The physical form of the antigen influences how one detects its reaction of an antibody. If the antigen is particulate, one generally looks for agglutination after the antigen by the antibody. If the antigen is soluble, one generally looks for the precipitation of the antigen after production of large insoluble antigen-antibody complexes. Agglutination tests. When the antigen is particulate, the reaction of an antibody of the antigen can be detected by agglutination, which is known as clumping of the antigen. The general term agglutinin is used to describe antibodies that agglutinate particulate antigens. When the antigen is erythrocyte, the term hemagglutination is used. All antibodies can theoretically agglutinate particulate antigens, but IgM, due to its high valence, is particularly good at agglutinin and sometimes infers an antibody may be one of the IgM class as a good agglutinating antibody. Looking at qualitative agglutination tests, these can be used to detect for the presence of an antigen or an antibody. The antibody is mixed with a particular antigen, and a positive test is indicated by agglutination of the particular antigen. For example, a patient's red blood cells can be mixed with an antibody to a blood group antigen to determine a blood type. Also, a patient's serum is mixed with red blood cells or known blood type to assay for the presence of antibodies to let the blood type this patient's serum. Quantitative agglutination tests. These can be used to measure the level of antibodies to particular antigens. So during the test, serial dilutions are made of a sample to be tested for antibodies and then fits for a number of red blood cells or bacteria or other such particular antigen is added. Then the maximum dilution that gives the agglutinin is determined. This is called the titer. The results are reported as a reciprocal of the maximum dilution that gives visible agglutination. Occasionally, it is observed that when the concentration of an antibody is high and has lower dilutions, there is no agglutination, and then as the sample is diluted, agglutination occurs. This lack of agglutination at high concentration of antibodies is called the prozone effect. Lack of agglutination in the prozone is due to antibody excess, resulting in very small complexes do not clump due to form visible agglutination. Application of agglutination tests. So these can be used to determine the blood types of antibodies to blood group antigens, to assess bacterial infections. For example, a rise in titer of an antibody to a particular bacteria indicates an infection of that bacterial type. For example, a four-fold rise in titer is generally taken as a significant rise in antibody titers. And although these tests are easy to perform, it is semi-quantitative. passive hemagglutination. This only works with particular antigens. However, it is possible to coat erythrocytes of a soluble antigen, such as a viral antigen, a polysaccharide, or a hapten, and use the coated red blood cells in a agglutination test for antibody to the soluble antigen. This is known as passive hemagglutination. This test is performed just like agglutination tests, and its applications include detection of antibodies to soluble antigens and detection of antibodies to viral antigens. There's also the Crumb's test, also known as the antiglobulin test. So looking at a direct Crumb's test, this is when antibodies bind to erythrocytes. They do not always result in agglutination. This can result from the antigen-antibody ratio being an antigen excess or antibody excess in some cases, electrical charges on the red blood cells preventing the effective crossing of the cells. These antibodies that bind to but do not cause agglutination of red blood cells are sometimes referred to as incomplete antibodies. This does not indicate that antibodies are different in their structure, although this was previously thought to be the case. Rather, this is a functional definition. In order to detect the presence of non-agglutinating antibodies on red blood cells, one simply adds a second antibody directed against immunoglobulin to coating the red cells. This anti-immunoglobulin can now cross into red blood cells and result in agglutination, and this is known as a direct Crumb's test. The direct Crumb's test is necessary to know whether a serum sample has antibodies directed against a particular red blood cell, and you must be sure that you can detect also potential non-agglutinating antibodies in a sample as an indirect Crumb's test is performed. This test is done by incubating the red blood cells with the serum sample, washing out any unbound antibodies, and then adding a second anti-immunoglobulin region to cross into cells. The application of this test involves the detection of anti-rhesus factor antibodies. So antibodies to the rhesus factor generally do not agglutinate red blood cells. Therefore, red cells from the rhesus plus children born to rhesus negative mothers who have anti-Rh antibodies may be coated with these antibodies. So to check for this, a direct Crumb's test is performed. To see if the mother has anti-Rh antibodies of serum, an indirect Crumb's test is performed. This test can be modified to be used for the measurement of soluble antigens. This test is called hemagglutination inhibition. It is called hemagglutination inhibition because one measures the ability of soluble antigens to inhibit the agglutination of antigen-coated red blood cells by antibodies. So during this test, a fixed amount of antibodies to the antigen in question is fixed with a fixed amount of red blood cells coated with the antigen. So also including this mixture, different amounts of the sample to be analysed for the presence of antigen. If the sample contains the antigen, the soluble antigen will compete with the antigen coated with red blood cells or binding to the antibodies, thereby inhibiting the agglutination of red blood cells. By serially diluting the sample, you can quantitate the amount of antigen in the unknown sample by its titer. This test is generally used to quantitate soluble antigen and is subject to the same practical considerations as the agglutination test. So looking at the radial immunodiffusion precipitation test. So in this, the antibody is incorporated into the agar gel as it is poured, and different dilutions of the antigen are placed in holes punched in the agar. As the antigen diffuses into the gel, it reacts with the antibody. When the equivalence point is reached, a ring of precipitation is formed. The diameter of this ring is proportional to the lower concentration of antigens as the amount of antibody is constant. Therefore, by running different concentrations at a standard antigen, one can generate a standard pure form which can form to quantitate the amount of an antigen in an unknown sample. This is therefore known as a quantitative test. If more than one ring appears in the test, more than one antigen-antibody reaction has occurred. This can be due to a mixture of antigens or antibodies, and this test is commonly used in a clinical laboratory for the determination of immunoglobulin levels in patient samples. You can also use immunoelectrophoresis. So this involves a complex mixture of antigens being placed in a well punched out of agar gel, and the antigens are electrophorized so that antigens are separated according to a charge. So after electrophoresis, a throw is cut in the gel and antibodies are added. So as the antibodies diffuse into the agar, precipitin lines are produced in an equivalence zone when an antigen-antibody reaction occurs. This test is used for the qualitative analysis of complex mixtures of antigens, although a crude measure of quantity fitness of the line can be obtained. This test is commonly used for the analysis of components in a patient's serum. Serum is placed in the well and antibody to whole serum in a throw. By comparison to normal serum, one can determine whether there are deficiencies on one or more serum components, or whether there is an overabundance of some serum component fitness for a line. This test can also be used to evaluate purity of isolated serum proteins. So looking at countercurrent electrophoresis, in this test, the antigen and antibody are placed in wells punched out in an agar gel, and the antigen and antibody are electrophorized into each other with a deformed precipitation line. So this test only works if conditions can be found where the antigen and antibody have opposite charges. This test is primarily qualitative, although from the fitness of the band you can get some measure of quantity. Its major advantages. So radioimmunoassay enzyme-linked immunosorbent assays, also known as ELISAs, are assays that are based on the measurement of radioactively associated immune complexes. In any particular test, the label may be on either the antigen or the antibody. Enzyme-linked immunosorbent assays are those that are based on a measurement of enzymatic reaction associated with immune complexes. In any particular assay, the enzyme may be linked to either the antigen or the antibody. Competitive ELISAs for antibody detection. So this is measurement of antigens and using known amounts of a standard or labeled antigen. One can generate a standard curve relating to radioactivity of an enzyme bound with the amount of antigen. From this standard curve, one can determine the amount of an antigen in an unknown sample. The key to this assay is the separation of the immune complexes from the remainder components. This is accomplished in many different ways and serves as the basis for the names given to the assay: precipitation of ammonium sulfate. So ammonium sulfate, 33 to 50% final concentration, will precipitate immunoglobulins but not many antigens. Therefore, this may be used to separate immune complexes from free antigens. It's been called the FAR technique. You also have the anti-immunoglobulin antibody, in which the addition of a second antibody directed against the first can result in the precipitation of the immune complexes and thus the separation of the complexes from free antigen. The antibody can be immobilized onto the surface of a plastic bead or coated into a surface of a plastic plate, and thus the immune complexes can be easily separated from other components by simply washing the beads or plate. This is the most common method used today, is referred to as solid phase RIA or ELISA. In the clinical laboratory, competitive RIAs and ELISAs are commonly used to quantitate serum proteins, hormones, drugs, and metabolites. So non-competitive ELISAs are also used for the measurement of antigen antibodies. So this involves the bead coating of the antigen being used for the detection of antibody in an unknown sample. The amount of labeled antibody is related to the amount of antibody in the unknown sample. This assay is commonly employed for the measurement of antibodies of the IgE class directed against particular allergens by using a known allergen as antigen and anti-IgE antibodies as a labeled reagent. This is called the RAS test. So during this, the bead is coated with antibody and is used to measure an unknown antigen. The amount of labeled secondary antibody that binds is proportional to the amount of antigen that binds to the first antibody. There are also tests for cell-associated antigens, so you can use immunofluorescence, which is a technique where an antibody labelled with a fluorescent molecule, such as fluorescein or rhodamine, or one of the many fluorescent dyes, is used to detect the presence of an antigen in a cell or tissue by the fluorescence emitted by the bound antibody. You have direct immunofluorescence, in which the antibody specific to the antigen is directly tagged with the fluorochrome. You have indirect immunofluorescence, in which the antibody specific for the antigen is unlabelled, and a second anti-immunoglobulin antibody directed towards the first antibody is labelled with the fluorochrome. Indirect fluorescence is more sensitive than direct immunofluorescence, because there's application. You also have flow cytometry, which is used to identify and enumerate cells bearing a particular antigen. Cells in suspension are labelled with a fluorescent tag by either direct or indirect immunofluorescence. The cells are then analysed on the flow cytometer. So in a flow cytometer, the cells exit a flow cell and illuminated with a laser beam. The amount of laser light that is scattered out of the cells as they pass through the laser can be measured, which gives information concerning the size of the cells. In addition, a laser can excite the fluorochrome on the cells, and the fluorescent light emitted by the cells can be measured by one or more detectors. So, final thing I want to touch upon is complement fixation. So antigen antibody complexes can be measured by their ability to fix complement, because antigen antibody complex will consume complement if not present, whereas free antigens of antibodies do not. So tests for these rely on the consumption of complement or termed complement fixation tests, and are used to quantitate antigen antibody reactions. This test will only work the complement fixing antibodies, and the best ones of those are IgG and IgM. So the principle of this complement fixation involves the antigen being mixed with the test serum to be assayed for antibody, and antigen antibody complexes are allowed to form. A control tube in which no antigen is added is also prepared. If no antigen antibody complexes are present in the tube, none of the complement will be fixed. However, if antigen antibody complexes are present, they will fix complement, thereby reduce the amount of complement in the tube. After allowing complement fixation by an antigen antibody complexes, a standard amount of red blood cells will be pre-coated with the anti-erythrocyte antibody added. The amount of antibody-coated red blood cells is predetermined to be just enough to be completely use up the complement initially added, if it was still there. If the complement was still present, no antigen-antibody complex is formed between antigen and antibody in question, all the red blood cells will be lysed. If antigen-antibody complexes are formed between the antigen and antibody in question, some of the complement will be consumed, and when the antibody-coated cells are added, not all of them will lyse. By simply measuring the amount of red cell lysis by measuring the release of hemoglobin into medium, one can indirectly quantitate antigen-antibody complexes in the tube. Complement fixation tests are most commonly used to assay for antibodies in a test sample, where it can be modified to measure the antigens.